my name is Nadereh Pourat. I'm the Vice Chair for Cost for CHBRP. I'm a faculty member at UCLA Fielding School of Public Health, Department of Health Policy and Management. I'm also Associate Director at UCLA Center for Health Policy Research. So under those two latter titles, I conduct healthcare research for particularly focused on underserved populations and access to care, quality of care, and costs of care. The purpose often is how can we improve the healthcare system to deliver better care to individuals who need it. And for the last few years, I've been conducting a lot of evaluations of the California Section 1115 Med-Cal waiver programs. A lot of these programs are focused mostly on populations that have the highest level of need and high healthcare utilization. The goal of the programs is actually to deliver services to these folks so that their needs are addressed, so their health improves, and the cost of care for them then declines. I was actually part of the original team when CHBRP was established. So CHBRP legislation, I believe, passed in 2022, and then I started working with Dr. Kaminsky, who was the original vice chair for cost. And we were at that time, we were actually just focused on establishing all of the infrastructure that's needed. And by that, I mean, developing the population model and developing the cost models. So we were working directly with Milliman to develop the cost model specifically. And as a result, what kind of data is needed to go to populate the cost model. So early on, I started doing those early analysis when we actually received the bills, and we over time just established, improved how the population model, how the cost model work. For the last few years, I've now taken on the role of the vice chair for cost, which is a combination of reviewing each year the processes that we have for cost estimation and updating those processes, figuring out how to do things better, and also establishing the team of analysts and overseeing the team, making sure that everything goes well, the team are supported in doing the analysis and doing the next stage of review of the products or the CHBRP reports, and making sure that those products are also of high quality and are useful to the legislature. Over the years, we have observed that for a variety of reasons, when these reports go to the legislature, often the cost impact is of great focus, and the reason whether a bill gets signed or not signed, actually not signed probably more often, because the cost impacts are a big concern. And so I think that's puts the work that we do in greater perspective, because we know what is riding on the analysis that we do. So it provides the incentive to do even higher quality and more accurate assessment. Yeah. So CHBRP has been really interesting and very impactful program. It is, over the years, I've seen a lot of different examples of how important it is for policymakers to actually have best data that could be provided to them in the short time frame that they have in order to make sound policy decisions. Our experiences include, for example, some of the legislation that upon further examination, we realize really does not make a difference.
Yeah.
It does add to cost. It doesn't really make a difference in terms of the outcomes that we're interested in, as well as legislation that has been extremely impactful and very important. So the fact that we are able to provide the data to make sure that sound policies made has been the biggest draws, the biggest points of interest for me personally, and a motivator to continue with the program. One of the recent projects that we finished was working with California Health and Human Services to needed information about what is actually required for the state if the state was to pursue unified financing. The idea of a single payer has been present in California for many years, goes back even to probably before, but during the Schwarzenegger administration, there was a bill that was attempting to do single payer in California. That didn't succeed, but there has always been interest and continues to be interest to change the way we finance care because it's a very fragmented way of financing and it leads to a lot of different, sometimes inefficient and not very effective outcomes. So that was one of the most recent activities that we have finished. And I think it was a very interesting project because we had to step back and think about these macro issues in terms of the overall approach to healthcare delivery in California and how it's financed. The other projects that I'm working on, one of them is evaluating the CalAIM. This is a major initiative in California to change healthcare delivery under Medi-Cal, but particularly focusing, the portion of it that I'm working on is focusing on delivery of very specific types of services. One is called enhanced care management, the other one called community supports, to individuals that are identified as high need, high cost, and to help these individuals get better care that results in better healthcare outcomes and hopefully also reduces the cost. So that we have submitted and done the interim evaluation, and currently we're working on the final evaluation where we're actually going to identify a lot more quantitative evidence of whether or not the program actually led to cost savings or did it change the patterns of healthcare delivery in a way that actually addresses the individual's needs. I also have another major project that I'm working on is evaluation of the Aliso Canyon disaster. This was a blowout of natural gas at the largest storage facility in California that led to release of hundreds of millions, hundreds of tons, hundreds of thousands, hundreds of millions, a lot of release of the natural gas for 4 months into the atmosphere, relatively unchecked. It took that long to actually cap the well and stop, but the impact, the health impacts of that disaster are being analyzed now. And so I am particularly leading the effort to look at healthcare utilization that occurred among individuals that were exposed to the blowout. And so that has led to a series of studies. We've looked at emergency department visits, we've looked at visits to providers, and we are continuing to look at other aspects of that particular disaster.